the rationale for this study was that patients with rheumatoid arthritis are at a twofold greater risk for venous thromboembolism and than the general population. And the influence of biologic DMARD treatment, especially TNF inhibitors, is not well known, or even the results in the publications are conflicting. And recently there was an observational study with patients with inflammatory bowel disease, and the results indicated that TNF inhibitors may have a protective effect against VTEs. To analyze our research questions, we took data from our German biologics register RABBIT, which is the prospective longitudinally followed cohort of RA patients. And in this register, patients can be enrolled when they start a BDMAT treatment, either original or biosimilar or JAK inhibitor treatment, or when they start a CSDMAT treatment after at least one DMAT failure. So we included patients in the study that were enrolled between January 2009 to April 2019, and had at least one follow-up, and these were more than 11,000 patients. In those patients, we analyzed the risk factors for VTEs, and for that we used first we calculated crude incidence rates, and then we used Cox regression with propensity score adjustment to adjust for the confounding by indication, which occurs when you have those different treatment groups. The main results from our study was first an incidence rate of VTEs of 2.6 per 1,000 patient years, and with the Cox regression we found that higher age, or age above 65 years, and higher disease activity, which was measured by the CRP, that those factors are associated with an increased risk for VTEs, and better physical function, as well as treatment with TNF inhibitors, were associated with a significantly decreased risk. For rheumatologists, these results are important because on one hand, they show that TNF inhibitors are not associated with an increased risk for VTEs, which was suspected from some. And they also show that it is very important to lower down the inflammatory level so that the CRP levels are not as high anymore. And in addition, that patients that have a higher age of 65 years and above and a lower capacity of physical function, that they have an increased risk for venous thromboembolism. A strength of our analysis is that we are able to compare a lot of different treatments with several or with different modes of action within one single cohort, within one study design, and that is, I think, the greatest strength. And as well, we have the rheumatologist report the adverse events at regular time points, so we don't have to count on spontaneous reports, but we have the regular time points, regular assessments from the rheumatologists on adverse events and on treatment details. The unanswered questions regarding VTE risk in RA patients is the risk conveyed by JAK inhibitors. This is something we couldn't analyze so far because we don't have enough events on JAK inhibitors yet. You know that JAK inhibitors are not so long approved for the treatment of RA in Europe than it was then in the USA and in other states. So at the moment, we are still accumulating observation in JAK inhibitors, and we hope with more person times on those treatments, we will also be able to analyze events of interest in those groups of treatments.